Welcome to Kids Doc Talk with Dr. Jennie. Today's guest is Dr. Randy Cohen talking to us about pediatric orthopedics. Dr. Cohen is a board-certified orthopedic surgeon with fellowship training in pediatric orthopedic surgery. He earned his doctorate at the University of Pennsylvania School of Medicine while completing a fellowship in bone molecular genetics. He completed his orthopedic surgery residency at the University of Pennsylvania School of Medicine and was chosen to be chief resident in orthopedic surgery. He then completed a year of fellowship in pediatric orthopedic surgery at the Scottish Rite Hospital for Crippled Children in Atlanta, Georgia. Dr. Cohen is a member of numerous organizations, including the American Academy of Orthopedic Surgeons, the Pediatric Orthopedic Society of North America, and the American College of Surgeons. He has authored more than 15 peer-reviewed publications. Dr. Cohen's area of interest includes sports injuries and spinal deformities in addition to children and adolescents. Visit kidbones.net for more information on Joe DiMaggio Children's Hospital Department of Orthopedic Surgery. Welcome, Dr. Cohen.
Welcome to Kids Doc Talk with Dr. Jennie. Dr. Jennie is a board-certified pediatrician and is the director of telemedicine at Pediatric Associates.
Hi, Dr. Cohen. Thank you for joining us.
Thank you for having me.
Good. I'm excited to talk about pediatric orthopedic surgery and all things kids' bones. So to get us started, orient us a little bit. What does a pediatric orthopedic surgeon generally see?
So great question. And again, thanks for having me. You know, before I talk about what a pediatric orthopedic surgeon sees, I think it's kind of helpful to define what an orthopedic surgeon is and what they do. And then you'll see where the pediatric context comes in. So orthopedic surgery is the treatment of the spine and the extremities of human beings. We generally don't do pets. It's pretty much humans. Right. And in order to become an orthopedic surgeon, you essentially had to go to medical school. And after medical school, you do a residency in orthopedic surgery, which is a 5-year process. And after you finish that, if you have particular interest in children, you do in pediatric orthopedics. And orthopedic surgery would include things like total joint replacements and injuries and hand and spine and tumors of the skeletal system. Total joint replacements, the sports medicine, those are the kind of things that fall within orthopedic surgery. Pediatric orthopedic surgery is all of that, except for people who are still growing or who have just recently finished growing. And we typically see children from birth to 25, 26 years old, and then we start kind of pushing them to go see a grown-up doctor. So what do we typically see? To answer your question, it's the most frequent thing we see is trauma, like children who've fallen down and broken a wrist or an ankle or a femur or a tibia or some part of their body. But then we also see all the other things associated with the skeleton. So children who walk with their feet in an unusual way, or children who are having pain in their legs, children who have curvatures of the spine, children who have one leg longer than the other, children who injured a knee or a shoulder and ankle playing some type of sport, children who are having difficulty with their fingers or their hands, children who have cerebral palsy, children who have other rare medical conditions that somehow affect the musculoskeletal system. So we kind of take care of that entire gamut of problems that occur in children, essentially with the skeleton.
Okay, so that's helpful, I think, to get us oriented. So, right, as a general pediatrician, a lot of times I'm referring to somebody like you when I need specialty specialty care regarding bones. But there are certain things that you probably see that you get referrals for that maybe are completely normal, right? And there's no real dysfunction. So the first thing that comes to mind for me is like in-towing, right? That's kind of the classic thing that we see as general pediatricians that we refer to you for, but mostly, right, we find that the answer is really just reassurance. What other things kind of live in that category of parents may think is abnormal, but in reality is normal kid growth?
So you kicked it off with the most common one that we see. And in-towing is, or sometimes called pigeon-toed, is when folks walk with their feet internally rotated so that their heels are to the sides and their toes are to the center. And a lot of parents see that and get very alarmed and concerned that this is a problem. Whereas in fact, it's just an anatomic variation and it's a normal part of development. Oftentimes as the children get older, it goes away on its own. There are some rare situations where internal rotation of lower extremities could turn out to be something more significant, but those are exceedingly unusual. And for the most part, we are just offering reassurance, and mostly by explaining to the families how there's kind of a natural history of the rotational profile of the lower extremities and how as they age, it changes. I will tell you that children who are internally rotated have a little bit of a silver lining to that, and that they have really excellent balance. They're typically very fast runners. They jump very high. They tire out less frequently. They have an easier time finding shoes that fit them. They've got some real talent in some sports that comes easy to them that may not come easy to other folks. So a lot of times when I tell the family that it's going to go away, they're very upset because it turns out they want their children to maintain those superpowers. The children who are externally rotated, which is another very common variable that you see in the lower extremities, they tend to have more difficulty with balance. They're not as fast running. They're not quite as facile at a lot of sporting activities because they have some more difficulty with that. And I also am able to tell them that with time, chances are that's going to go away too. So in terms of the rotational profile thing, that's one of the common things. The other common things that people get concerned about are bow-leggedness, when the legs kind of have a little bit of a curve. Looks like your child just got off a little miniature horse maybe that they've been riding around. Bow-leggedness is a normal component of development, and every baby should be bow-legged. It typically starts going away at around 18 months of age, and it can persist a little bit beyond that. There are some other things that can cause bow-leggedness that are significant. Certain types of dwarfism cause it. Certain vitamin deficiencies can cause it. There's some rare diseases of the tibia that can cause it, but it usually has a very different look that the pediatricians are very adept at picking up. The bow-leggedness gives rise to completely straight legs at some point between the ages of 2 to 3.5 or so, but they don't stop. They keep going, and then you end up knock-kneed. So that's another thing that we see commonly. Oh, my child is knock-kneed. Look at the knees, they're knocking into each other. And the family says, we need a brace, we need to do something. This is another normal developmental process where they kind of hit their peak of knock-knees somewhere between 3.5 and 6 or so. And by the time you're between 8 and 10, you end up with what you're going to keep as an adult. And normally, a slight amount of knock-knees is normal, about 8 degrees. So actually, to be normal, you end up with a mild amount of knock-knee. There's a perception amongst families that children who have either the in-toeing or the out-toeing or the bow-leggedness or the knock-knees need to be put in some type of contraption to make them better because they saw the movie Forrest Gump and grandma said that I had to wear a brace when I was a child, and people come in from countries in South America all the time with a very expensive contraption they purchased and they say, look, we wore this and we got better. Well, you would have gotten better if you rubbed a banana on your head because the natural history is going to get better anyway, and at least then you'd have something to eat. The braces do not work, and study after study has shown that they don't do anything. So that Forrest Gump type of concept of wearing braces for the correction of this type of mild angular deformity or rotational deformity is a myth. It doesn't work, and you don't have to torture the child and have them get called out by other people. Look at the brace that Johnny's wearing and stuff like this. So those would be some of the most common normal things that we see.
So that's helpful. And, so you're kind of talking about one of my favorite things, which is the ability for us to do nothing, which is my favorite thing as a pediatrician, to tell someone, guess what, we have to do nothing. My other favorite thing to do as a pediatrician is to try to prevent. So you mentioned one of the very common things that you see, like is injuries, right? Trauma, fractures, things like that. And I had a guest on a few episodes ago who's a PZR doctor, and we kind of talked about, a little bit about injury prevention and things that she steers her kids away from and things that she tries to sort of intervene to recommend to patients to avoid. As in your specialty, is there any kind of activity or any kind of like prevention that you would like to sort of universally have it be known? Like you want generally kids to avoid what, if anything?
So, we have, freedom in the United States to do whatever we want, even if it's not a great idea. And so I'm not going to advocate that people should not or should not do something, but I think you need to go into it with open eyes and an open brain so that you cannot end up with damage to that brain. So when we look at sports and other activities that children participate in, and adults too, we divide them into sports that actually involve intentional trauma, sports that might have some trauma in them, and sports that don't have trauma in them. So a sport that doesn't have trauma in it, that would be lower risk, would be something like tennis, right? You can play tennis, of course it's possible to somehow get injured, but the object of tennis is not in any way to tackle or hurt your opponent or hit them in the head or do anything like that. And it's pretty unlikely that you're going to have a collision with the player who's on the other side of the net. A sport that has some risk, but not tremendous risk, would be something like baseball. So baseball has risk. It is possible to collide with another player. That's not really the intention of the sport. It sometimes happens inadvertently as a consequence, but it's not like the object of the sport, right? So it's going to have an increased risk of injury, but not tremendous. Then you got sports where the object is to actually hit the other person. Football, you try to hit the other person. Rugby, you try to hit the other person. Boxing, you try to hit the other person. Some types of martial arts, you try to hit the other person. So if you're going to stratify things into risk and you want to say, is this a risky activity or not a risky activity? You've got those things like basketball, which may inadvertently result in injury, but are not designed to injure. And then you've got those things where you're actually trying to tackle people that are going to have a higher profile. So I like to think of them along those lines. And that very much also applies to the risk of head injury and concussion, which kind of goes hand in hand with that. Because wherever there's a high risk of injury of the musculoskeletal system, there's also a very high injury of the head for one of these contact type of things. Obviously, tennis is going to have a much lower concussion rate than football, right? So, you know, one of the fortunate things that we have in our group is, besides the fact that we have folks who specialize in scoliosis and who do sports medicine and do the hand and do angular deformities of the lower extremities and do limb length inequalities, we also have a couple of people who are rather prominent in the national scene on concussions and head injury. And, you know, it's one of the reasons that I think we've had some really great success in helping to prevent people from having problems, because head injuries are a real problem among our sporting kids. So when you say, what are those things that really worry me? The head injuries worry me among the most, because if someone gets a fracture, I can fix that, you know? But if someone gets a head injury, I can't necessarily fix that. And particularly if they get a head injury and then before they've had an opportunity to recover, they've returned to sport prematurely. So when you ask, you know, what are those things that parents could do? I would say if injury is a very big problem for you, and that's a very big concern, it's going to kind of temper what you're going to do. It may guide what sports you guide your children into. If they are going to be doing a sport that's higher risk, then knowing the rules and knowing how to adhere to them properly and how to make sure you're adequately hydrated, that you're warming up with some type of dynamic stretching prior, all of these types of things do help prevent injury. But certain injuries in certain sports are simply unavoidable.
So you mentioned concussion, and that's definitely an area I have a lot of questions about. Obviously in pediatrics, we see a lot of kids who were worried about concussion and were asked to sort of, right, evaluate, stratify their risk and determine when they're okay to return to sports, right? Return to activity. So obviously you guys have a whole, you know, robust clinic, but a little bit from like a parent's view or even or general pediatrics view, what are the consequences of us making that decision inappropriately? In other words, if we allow someone to return to play or to activity too soon after a concussion, what is the potential fallout from that?
So, my two partners who deal with this, Dr. Fazekas and Dr. Dressing, who do research on this on a national level and have set up an entire clinical program for this, are certainly better equipped to answer that than I am, but I can still give you a pretty decent response. So the old thinking of taking away somebody's cell phone and putting them in a dark room for a week and not letting them do anything is kind of antiquated and no longer really has research support for it. There's now evidence that within a relatively short period of time, they can return to a learning environment and that it's somewhat beneficial, and that early exercise also has a beneficial effect on the recovery from concussion. But there are multiple risk factors and other components associated with the injury and in the neurologic exam that alter what the plan would be. And so this is why if someone does sustain a concussion, they really need to be evaluated by somebody who does concussion as a major part of their practice, because the consequences of early return are significant. So when you have a concussion, the problem is essentially one of channels that allow different types of salt components like sodium and potassium, things like this, that flow in and out of the nerve cells. Those channels become leaky on a temporary basis. And during that period of time, if you get a second injury, call it a second injury to the nerve, or a double crush or a double injury, that leakiness can actually become to the point where there's actually swelling and actually damage that can be irreversible. So there are real consequences to returning before recovery has occurred. And furthermore, there's not a fixed amount of time from the injury to when it's okay to get back to doing things. That's a decision that's made by those professionals as a result of exam, neurologic exam, neuro testing that they do. They have this special impact testing, which is a computerized test that's done. Sometimes they have to get blood tests. Sometimes they actually need to scan the children. And then they're able to say when it is safe to return back. And they can also guide the return to exercise. It turns out that exercise helps wash away some of the bad chemicals that get created in the neurologic system that need to be washed out to help with recovery. And they know what needs to be done for those children to prevent that double injury, which would be rather important. So I wish I could say, oh, here's what you do, but it's just not that simple.
I think that's a really important nuance to this, right? Because we sometimes have parents who want that answer, right? Or even kids, right? Because usually it's athletes, right? And they're motivated to get back, and they want to hear an answer like after a week, right? Or after 5 days. And that's really not the case. It's really sounds like clinically determined and very individualized depending on each child and the extent of their injury.
Right. It could be quick. It depends on the severity, the symptoms that they had, et cetera. There used to be hard and fast rules that were followed for many years, but as time goes on and as data gets gathered, I've been told by Dr. Fazekas that we no longer are able to give a specific duration for the amount of time that you need to withhold potential injury, because it turns out not to be borne out by the science. So it has to be individualized for the individual based on age, maturity, the neurologic exam, and a host of other factors, which are almost beyond my capability because it's just not my area of expertise.
Okay, that's helpful. So let's switch gears a little bit and talk about something that I think probably has some more concrete and standard restrictions and protocols, which is scoliosis, right? So we see tons and tons of scoliosis. We screen for scoliosis all the time. And when we're concerned, we, meaning general pediatricians, when we're concerned, we send to you. So tell us a little bit about what scoliosis is and what are the different treatment options available by the time the child actually gets to see you.
All right, sure. So scoliosis turns out to be not terribly uncommon, but also not common. So normally what happens is either it gets picked up by the pediatrician who has them at a well patient visit, kind of bend forward and look at them from behind, what we call an Adams forward bending test. And if they see an asymmetry, then they'll either get an x-ray on their own or they'll refer them to us for x-rays. Or sometimes it's noted by a parent. Sometimes they notice that one shoulder is higher than the other, or one hip is higher than the other, or when the child is wearing a bathing suit, that the hips or the contour of the waist looks different on one side than the other. Rarely is pain a presenting symptom for this. It's usually a cosmetic type of appearance that they notice an asymmetry. Once that gets noticed and we see it, I say to the family, The cosmetic ability to see that there's a difference from one side to the other gives us a hint that something's going on, but we really don't know if you have scoliosis till we take an x-ray, because it's an x-ray diagnosis. And there's a technique that we use to measure how angled the individual vertebrae are on the x-ray called the Cobb technique, which is pretty much a worldwide agreed upon way of doing this. So if I measure it in Coral Springs or I measure it in Calcutta, the numbers are going to be within a few degrees of each other, and it's got good integrity and good consistency. If the angle between the most tilted vertebra is less than 10 degrees, we say, you know what? It's not normal, but it's not scoliosis. And we're going to call that spinal asymmetry. Spinal asymmetry rarely goes on to become scoliosis, but it can, particularly if the child has a lot of growth left to go, because it's growth that drives scoliosis to get worse. If the curve on that special measurement is between 10 and 25 degrees, then we call it a small curve. Small curves do have the potential to become larger curves, particularly if you still have growth left to go, but no one has been able to show that any particular exercise or brace or diet or sleeping position or being hit with a fish or anything is going to actually make a difference. There were some exercises that were promoted for this called Schroth exercises, which were very expensive type of physical therapy that they were trying to show made some kind of difference on that. It's really difficult to say if it's truly a difference because the folks in the studies were also in all types of bracing. And so it's not clear if that was really making a difference. But at this point, I can't say definitively that there is a true difference from any type of intervention. If the curve makes it between 25 and 40, then we call it a medium. And the medium curves are where we have the most opportunity to potentially stop things. Those are the ones that are a candidate for a brace, but only if you're still growing. Braces don't work if you're not growing. If you are growing and you have a curve between 25 and 40, a brace is going to be your friend. And there are numerous studies that show that the brace either stops the curve from progressing or slows the curve from progressing in a large number of those children. So we do advocate the use of the brace, and there are different types of braces that are used based on the type of the curve, the location of the curve, etc. Certain curves have qualities that also get us concerned. There could be other underlying issues. Curves that tend to go to the left, for example, curves in very young children, curves that have an unusual appearance to them. Those get an MRI, even if they're small curves. Whereas curves that have a more typical appearance with normal neurologic exam in the office, 25 to 40 degrees, still growing, get a brace. You may wonder, how do we know if they're still growing? Well, there's a couple of different ways. There are x-ray findings you can see in the x-ray that show the maturity of the growth plates, and the growth plates go through a very predictable sequence of maturation that give you an idea of how much growth is left remaining. So that's a very good way in both boys and girls. Girls can have periods, and very first period, I use the fancy word menarche for, but it just means very first period. But the time from menarche to the time of cessation of growth is typically about 2 years. Can vary from 18 months to 3 years, but it usually clusters pretty close around 2 years. So I know if it's under 2 years since menarche and I have a young female come in, now I'm concerned of progression because I know they still got growth to go. The third way I can figure out growth is I can look at, in boys, I can see whether or not they're ready to shave. If they're ready to shave, they're pretty much done. And I can also look at the height of their biologic parents to see if they're an outlier or if it makes sense of what their height is. Now, if that curve comes to be more than 40 degrees, but less than 50, then we call it a large curve. We still treat those with a brace, but we know that the brace loses some effectiveness in that population. When curves get over 50 degrees, that's when we got to worry. Those are the ones that get surgery. And the reason they get surgery is not because they're having a problem with a 50-degree curve, other than perhaps the cosmetics of it, but we know that essentially 100% of curves greater than 50 degrees are going to continue to get worse and worse and worse, even if you're done growing. When it gets into the 70s or 80s, it starts affecting the heart and the lungs in an irreversible fashion. We can't make that up. So before we get to that point, that's when we're going to intervene with surgery. So a curve over 50 gets intervened to prevent that eventual problem. We're not doing the surgery because we want to make it cosmetically look better, although that's a nice side effect. We're really doing it to prevent progression and to prevent the dreaded complications to the heart and lungs. The final point would be that if you have a curve that's less than 40 degrees and you're done growing, you're skeletally mature, it freezes and you're kind of home free for the rest of your life. Now, that doesn't mean I'm happy with someone with a 39-degree curve. I'd rather them have a smaller curve. And that's why as soon as it goes above 25 and they're still growing, I want to get them into a brace.
So that, I think, for the most part, is really good news for kids who are still growing. But what options are available for kids who are no longer growing and maybe have that smaller or medium size, right, Cobb angle, where it's not necessarily functionally going to be a problem? We're not worried about them not being able to breathe well, right, or have any cardiac consequence, but cosmetically, they're not happy. Are those candidates for surgery?
So they're not a candidate for surgery unless the curve's above 50. Because the risk-benefit ratio just does not make it worthwhile. We're talking about a fairly major surgery that does have very significant potential risk. So the cosmetics of it would not be a suitable motivation. There are some situations where the curve is predominantly in the lumbar spine and a very thin person where they're so unbalanced and it looks so ridiculous that we have to do something to intervene because they can't even stand up without falling off to the side. But for the most part, the cosmetics of curves that are under 25 degrees are really good. In fact, it usually takes a trained eye to even pick it up. A lot of times they're very difficult to see. They get missed very frequently. And it also depends a little bit on your body habitus. Children who are really thin, who have very minimal body fat, yeah, you can probably see a curve that's 25 degrees, but you're going to have to try. It's not going to be easy. Curves that are in that medium range, 25 to 40, you'd be surprised how many people I see with a curve of 38 degrees who you can't even tell on physical exam. It's not until you take an x-ray that you can see it. So oftentimes they're very well disguised. And then the other issue is some of these kids who have a curve that is noticeable because they're kind of thin and it's in that 25 to 40 range, not bad enough for surgery. When you see them as a kid, they're kind of at their lowest body fat they're going to be in their entire life. You know, a adolescent girl or adolescent boy typically, and there are exceptions, but typically have a pretty low amount of body fat. They're kind of all muscle. And what ends up happening is it becomes more visible. And as they age into the later teens and the early 20s, and they start putting on some muscle mass and some body fat, which is not to say they're getting fat, but just biologically they start distributing some fat on their body, which is a normal part of development, it becomes harder and harder to tell that anything's going on at all. So oftentimes those folks who feel very devastated and feel very self-conscious that everybody can notice that I have a curve. First off, most people don't even know they have the curve. And secondly, as they age, it becomes less and less apparent. There's a concept of magnification of your own symptoms that make you think that things are worse than they actually are. And the example that I usually give people is that if you've ever bitten the inside of your cheek and you get a little sore on the inside of your cheek and you start filling it with your tongue, your brain convinces you that there's an enormous lesion on the inside of your cheek. And if you take the time to evert your cheek and look in a mirror, you're going to see what a small injury it actually is and be surprised how your brain had magnified it. And many times children who have that scoliosis in the range that you're referring to have magnified in their mind by staring in the mirror and thinking about it all the time that it's way more visible than it actually is. And I would assure you that if they actually asked other people who they've just met and said, can you tell that I have scoliosis? They'd say, what are you talking about? So we do have to reserve those children who are candidates for surgery for the larger curves for a variety of reasons, but it's mostly for safety.
That totally makes sense. And having taken care of some of those kids post-operatively after surgery, I can definitely attest to, you know, it being a challenging recovery, right? And certainly not a benign procedure. So I can definitely understand that the risks of that need to be really, really weighed very carefully. So we covered a lot of ground. We talked about normal things that you see, right? Stratification for sports and injury, scoliosis, concussions. So I'm going to ask you what I always ask everybody at the end, which is like, what is the one thing that you want parents to know about pediatric orthopedics, whether it's prevention of injury or things that you wish people knew were normal or any kind of like pearls or takeaways?
So I would say that, people around the country are going to be listening to this discussion who are not necessarily in our backyard in South Florida. So, we're an unusual group of 10, about to be 12, that covers the entire gamut. We've got 6 offices, and, we try to make room to put people in every single day for fractures or acute injuries to make sure they get taken care of. I think what you want to do wherever you are is make sure that the provider that you're going to see who's in pediatric orthopedics is someone who actually has fellowship training and spends their time focusing on children, because children are not little adults. We treat a meniscal tear in a child differently than we treat an adult. We treat a fracture in a child differently than we do an adult. A child who's got cerebral palsy, we have to treat the family, not just the child. This is like it's a very complicated thing, and it does take, specialized training. The volume that goes through somebody's office and the experiences that they see on an ongoing basis make it very, very helpful. So wherever you are, just make sure you're seeing a place that's busy and kind of is really focused on the child, not just an afterthought where you're, crowded in next to some old lady who fell down and broke her hip. The other thing that I think that's important for families to know is that children need to play. They need to have fun. They don't have to do sports. It's not a requirement, but there's lots of benefits to being active. It doesn't have to be in a team sport, but exercise is as important as anything else that you can do in your life. As important it is to read and learn math and learn other skills. Physical education is just that, it's education, because you need to learn how to maintain this one instrument that you have, that you inhabit, that's got to last you maybe close to 100 years. And it's not going to happen by sitting around, and it's not going to happen by eating foods that are designed to destroy you. You have to take care of your instrument, because if you don't, nobody else will, and nobody else is going to be responsible for it. So what I'd like to see is parents think very carefully about how I can keep my child engaged in something that involves some physicality. It doesn't have to be team sports. It doesn't have to be football, but it should be something. It could be walking. It could be something, but I think you need to think about that carefully. And that's the greatest gift you can give somebody.
I love that answer. And that's actually great. That's a great way to tie everything together. And I can certainly appreciate this is coming from somebody who sees kids and has pediatric experience, because that was a very pediatric answer. Move your body, because a lot of times that I find is the solution to a lot of issues in problems that we're seeing in kids, is that we're not moving our bodies enough.
I just wanted to mention one other thing. I don't know if this is worthy of keeping it or not. We were talking about children who've had scoliosis surgery, which I think is an important topic, because there's a fear associated with, okay, what if I need the surgery? It's going to be terrible. It's going to be awful, right? Mm-hmm. So things have really changed in the last 20 years. And we have different pathways now and different medicines that we're able to give folks preoperatively to help. So about 1/3 of the kids that we operate on now for scoliosis surgery leave the hospital on the 3rd day. Almost all the rest leave on the 4th day. Almost everybody is completely off pain medicine within 8 days. They're back to school, many of them within 3 weeks. We tell them 6 weeks, but many times at 3 weeks, they're like, I'm ready. So it used to be a much greater imposition. People were in braces or in casts, or it was a long-term prognosis, and I'm never going to get back. Now they're recovering so quickly, it's absolutely astounding. And most of the time when they come back to the office and I see them and I say, was it worth it? They go, worth it? Look at me. They're rather happy about it. So I just don't want to have that idea that it's like it is a major surgery, but it's something that the children are so resilient and do so well with. I don't want that to in any way be an impediment for somebody to consider something that really is for their long-term health.
Fantastic. Okay. Thank you for that clarification. I appreciate it. And thank you again for your time this afternoon.
The pleasure is mine.
Make sure you like us on Facebook and follow us on Instagram and Twitter. Thank you for joining us on Kids Doc Talk.